Let me say one thing clearly before we begin. This is not about fear. It is not about walking away from your doctor or abandoning medications that are genuinely helping you. Please hold on to that as we go through this together. Your physician knows your history, your body, your test results, and your individual circumstances in ways that no video can ever replicate or replace. What this is about is something every person over 60 deserves and rarely receives enough of. It is about being genuinely informed. It is about walking into your next appointment carrying the right questions, the specific, thoughtful questions that open up conversations that most patients over 60 have simply never had with their doctors. Because those conversations, when they happen, change outcomes. And they only happen when the patient walks in knowing what to ask. Here is something most people over 60 have never been directly told. The body at 65, at 70, at 75 processes medications in ways that are fundamentally different from how it processed them at 45. The kidneys filter more slowly. The liver breaks down compounds with less speed and efficiency. Changes in body composition mean that drugs distribute through tissue differently than they once did. And the brain, the aging brain in particular, responds to certain chemical compounds with a sensitivity and a prolonged reaction time that simply did not exist in earlier decades. What this means in everyday terms is that a medication prescribed 7 or 8 years ago, at a different body weight, with different kidney function, under different health circumstances, may not carry the same balance of benefit and risk today that it carried when it was first written. And in the vast majority of cases across the country and around the world, no one has sat down and looked at that with fresh eyes. That gap between what was once appropriate and what is appropriate now is precisely where problems develop quietly, invisibly, and over long stretches of time. And most people never know to look there until something has already gone noticeably wrong. So today I want to walk you through 7 categories of medication that deserve a more informed and more thorough conversation with your doctor if you are over 60. Not because these are universally harmful, not because the doctors who prescribed them acted carelessly, but because in older adults specifically, they carry risks that are underestimated, underexplained, and far too rarely brought into the open. Stay with me through all 7. Because the ones toward the end are the ones that consistently surprise people the most. The first category is prescription sleeping pills, particularly the family known as benzodiazepines, and the newer group called Z-drugs, which includes zolpidem, widely known as Ambien, along with similar medications prescribed under various names for difficulty falling or staying asleep. Here is what most people are never told when these medications are first prescribed. After 60, the brain becomes considerably more sensitive to sedative compounds than it was in earlier decades. What produces a mild and manageable calming effect in a younger nervous system produces a deeper, more prolonged sedation in an older one. And while a person taking these medications may feel subjectively that they slept, may even feel they slept reasonably well, the actual structure of that sleep, the deep restorative stages the brain and body depend on for genuine overnight repair and recovery, is frequently suppressed by these medications rather than facilitated by them. But here is the part most people never hear clearly enough. The sedative effect does not resolve cleanly by morning in people over 60. It carries forward into the waking hours. It affects balance, coordination, reaction time, and the clarity of thinking and judgment in ways subtle enough that the person experiencing it often does not identify it as medication-related. It simply feels like being a little slower, a little foggier, a little less steady than usual, until a fall happens. And falls after 60 are not small events. They are among the most serious threats to independence, physical safety, and long-term quality of life that older adults face. The connection between regular sedative sleep medication use and fall risk in people over 60 is one of the most consistently documented findings in all of geriatric medicine. It is not a footnote, it is a central concern. And yet these prescriptions are written and refilled for years in older adults without the conversation about alternatives ever genuinely and thoroughly taking place. If you or someone you love takes a sleeping pill regularly, the most valuable question for the next doctor's visit is simply this: before continuing this medication long-term, have we truly and thoroughly explored sleep hygiene strategies, behavioral approaches, and safer alternatives specific to my age? That one question, asked calmly and directly, can open a door that changes things meaningfully. The second category is a class of medications known as anticholinergics. And I want to spend real time on this one because most people have never heard this word, and yet they may be taking something from this category every single day without any awareness of it. Anticholinergic medications work by blocking a neurotransmitter called acetylcholine in the brain and nervous system, and they appear across a surprisingly wide range of very common, very familiar products. Certain older antihistamines, diphenhydramine being the most prevalent, found in many over-the-counter allergy tablets, and in nearly all over-the-counter sleep aids sold under names like Benadryl, ZzzQuil, and Simply Sleep. Certain medications prescribed for bladder urgency and overactive bladder. Some older antidepressants. Certain medications used for nausea, stomach cramping, and motion sickness. Here is why this matters with such particular weight after 60. Acetylcholine is one of the primary neurotransmitters responsible for memory, attention, learning, and the quality of cognitive processing. When medications consistently block this system over weeks, months, and years, the cumulative impact on the older brain accumulates in ways that multiple large studies have examined with genuine concern. Memory difficulties that appear gradually, trouble sustaining attention, confusion that settles in slowly and begins to feel like simply how things are now, brain fog that gets attributed to age, to stress, to poor sleep, when it may in meaningful part be a pharmacological effect that no one has ever identified and named for the person experiencing it. Geriatricians specifically assess what they call anticholinergic burden, the total cumulative cognitive weight of all anticholinergic medications a person carries simultaneously when evaluating memory and cognitive health in patients over 60. It is a formal part of geriatric clinical practice, which tells you that the medical community understands this risk deeply. The gap is in how reliably that understanding reaches the people it most needs to reach. The question to bring to your doctor is this: looking at everything I currently take, including things I buy without a prescription, are any of them anticholinergic? And if so, does a safer alternative exist that we have not yet seriously explored? That single question, asked with calm clarity, may be among the most important medical conversations you initiate on your own behalf. The third category is proton pump inhibitors, the medications abbreviated as PPIs, including omeprazole, lansoprazole, esomeprazole, and pantoprazole, sold under brand names including Prilosec, Nexium, Prevacid, and Protonix. These are among the most widely prescribed medications anywhere in the world. Most of them are now also available without any prescription. They reduce stomach acid. For specific, well-defined conditions and for appropriately limited durations of use, they are clinically appropriate and genuinely effective. But here is what the vast majority of people taking them long-term have never been clearly told. Stomach acid, uncomfortable as it is when it appears where it should not, performs functions in the body that are essential and not easily substituted. It is the primary mechanism by which the body absorbs magnesium, calcium, and vitamin B12 from food. When stomach acid is consistently and significantly reduced over months and years, the absorption of these nutrients declines in ways that carry real and serious downstream consequences. Consequences that grow more significant, not less, as the body moves past 60. Low magnesium over time affects heart rhythm, muscle function, sleep quality, and the body's capacity to regulate blood pressure. Low calcium contributes to progressive bone density loss at exactly the stage of life when bones are already most vulnerable. And low vitamin B12, this is the one that surprises people most consistently, produces neurological symptoms that closely and convincingly resemble early cognitive decline. Tingling and numbness in the hands and feet, persistent deep fatigue, memory lapses, mood changes, progressive weakness. Many people over 60 who have been on a proton pump inhibitor for several years are living with some or all of these symptoms right now, with no awareness that the medication they reach for each morning could be a meaningful contributing factor to what they are experiencing. If you have been on a PPI for more than a few months, this conversation with your doctor is overdue. Are my levels of magnesium, calcium, and B12 being monitored regularly? Do I still need this medication at this dose and this frequency? Are there dietary changes or less suppressive alternatives we have not yet genuinely explored together? The fourth category is non-steroidal anti-inflammatory drugs, The medications most people recognize as NSAIDs, including ibuprofen, naproxen, diclofenac, and related compounds available both by prescription and freely over the counter. Used occasionally by a younger person for acute pain or inflammation, these are generally well tolerated and effective. But after 60, three specific and distinct shifts occur in the risk profile of regular NSAID use, and most people have never had any of them explained to them directly. The first is the kidneys. After 60, kidney function operates with meaningfully reduced reserve. NSAIDs affect the blood flow dynamics within the kidney in ways that a younger kidney compensates for with ease. The older kidney compensates far less easily. With regular use, this can contribute to a gradual and entirely silent deterioration in kidney function that accumulates over months or years before it appears in any blood test, and often before any symptom gives the slightest indication that anything is happening. The second is the gastrointestinal lining. After 60, the protective mucosal barrier of the stomach and intestinal tract is more vulnerable to disruption than in earlier years. NSAIDs reduce the prostaglandins that maintain this barrier. The result is a significantly elevated risk of gastrointestinal bleeding in older adults, a risk that increases with regular use rather than occasional use, and increases further when combined with blood thinners, steroids, or other medications that many older adults are already taking. The third is the cardiovascular system. Regular NSAID use carries modest but real associations with elevated blood pressure and increased cardiovascular risk, associations that become more clinically meaningful as the baseline cardiovascular risk that comes naturally with age increases year by year. If you manage chronic pain regularly with NSAIDs, the conversation worth having involves alternatives. Topical preparations applied directly to the site of pain. Acetaminophen used carefully at appropriate doses. Physical therapy, targeted gentle movement, warm and cold application. These do not always fully replace NSAIDs in every situation, but they carry a fundamentally different risk profile, and that difference matters more with every passing year after 60. The fifth category is muscle relaxants. Medications including cyclobenzaprine, methocarbamol, and carisoprodol, frequently prescribed for back pain, neck pain, and muscle spasm, often in people who have been managing these issues for many years. The central concern with this category for people over 60 comes down to one fact that is frequently and consequentially overlooked. Muscle relaxants do not work directly on the muscles. They work through the central nervous system. Sedation, slowed cognitive processing, and impaired coordination are not side effects that happen in some people who take these medications. They are the mechanism. They are how the medications produce their effect. And in older adults, these central nervous system effects are amplified considerably and persist far longer than they do in younger nervous systems, for the same physiological reasons we discussed with sleeping pills. Sedation combined with impaired balance combined with reduced reaction time in a person over 60 who may already carry some degree of postural uncertainty creates a compounding fall risk that geriatric medicine has identified and flagged with consistent urgency. And yet, muscle relaxants continue to be regularly prescribed to older adults with chronic musculoskeletal pain, often without adequate exploration of alternatives that do not carry these risks, and that may in fact address the underlying source of pain more effectively and more sustainably. Targeted physical therapy, progressive gentle stretching, postural correction, body mechanics education, direct heat and cold application. These approaches work toward resolving the mechanical origin of the pain rather than sedating the nervous system around it. They support the body. They do not simultaneously and invisibly increase its vulnerability. The sixth category is blood pressure medication, and precision matters here more than in almost any other category on this list. This is not about whether elevated blood pressure should be treated after 60. It should be. Appropriate blood pressure treatment in older adults provides genuine and well-documented protective benefit. This is about something more specific, the risk of overtreatment, and what happens in the body of an older adult when blood pressure is reduced lower than the aging body actually functions well at. After 60, and with increasing significance after 70, the brain, the kidneys, and the cardiovascular system have adapted over many decades to receive blood flow at certain pressure levels. These organs have calibrated around those levels. When blood pressure is brought meaningfully below what these organs have come to depend on, through medication dose, through dehydration, through drug interactions, or simply through the physiological challenge of moving from lying or sitting to standing, the consequences range from uncomfortable to genuinely dangerous. Dizziness upon standing, orthostatic hypotension, is one of the most common and most consistently underreported experiences among older adults taking blood pressure medication. It occurs when the transition from a resting position to standing causes a momentary pressure drop before the body's compensatory systems can respond. The experience is lightheadedness, sometimes visual darkening, sometimes a sudden and frightening sense of instability, and it is a well-established and primary contributor to falls in this population. The conversation worth having is not about whether to treat blood pressure. It is about whether the specific target, the specific medication, and the specific dose currently in place remain genuinely right for your age, your kidney function, your hydration patterns, your activity level, and the way you actually feel as you move through your daily life. Blood pressure management after 60 should never be a decision made once and left unexamined for years at a time. The seventh category, and consistently the one that surprises people most completely, does not involve prescription medications at all. It involves the long-term, habitual daily use of certain over-the-counter products that most people have never once considered as carrying meaningful clinical risk. Specifically, long-term regular use of stimulant laxatives and long-term daily use of calcium-containing antacids in amounts beyond what the body can appropriately process and clear. Stimulant laxatives work by chemically prompting the muscles of the bowel wall to contract. Used occasionally and briefly, they are appropriate and helpful. Used every day over months and years, they can progressively alter the bowel's own intrinsic ability to move its contents through naturally and independently, without pharmacological prompting. A quiet dependence develops. After 60, when bowel motility is already naturally slower and the nervous system governing gut function is already less responsive, this cycle is both easier to fall into and considerably harder to reverse than most people are ever told. Calcium-containing antacids, the chewable tablets that sit in kitchens and bathrooms everywhere and are reached for casually after meals without any sense of clinical concern, when taken daily over extended periods in older adults, can contribute to elevated calcium levels in the blood and urine, with consequences for kidney function, vascular tissue, and cardiac health that are almost never discussed in the context of something bought without any prescription or guidance whatsoever. The point is not that these products are harmful when used appropriately, occasionally, and for their intended purpose. The point is that their unrestricted availability creates a widespread and completely understandable assumption that daily long-term use carries no meaningful risk. After 60, that assumption deserves to be examined honestly and directly with a doctor who has your complete picture clearly in front of them. So here is where everything comes together. 7 categories: sedative sleeping medications and their amplified and lingering effect on the aging brain and their well-documented relationship to fall risk. Anticholinergic drugs and their quiet, cumulative, and frequently unrecognized impact on cognitive function in older adults. Proton pump inhibitors and the nutrient absorption consequences that accompany years of consistent acid suppression. NSAIDs and the kidney, gastrointestinal, and cardiovascular risks that shift meaningfully and specifically after 60. Muscle relaxants and the central nervous system effects that compound postural instability and fall risk in older adults. Blood pressure medications and the genuine and specific danger of overtreatment and orthostatic drops in an aging vascular system. And long-term, over-the-counter habits that most people have simply never been invited to question. None of this is a verdict. None of it means your care has been inadequate or that the medications you currently take are wrong for you. What it is an invitation. A specific, informed, confident invitation to have a more complete and more thorough conversation at your next appointment than perhaps you have had until now. Write down everything you take, every prescription, every over-the-counter product, everything taken occasionally. Bring that complete list to your next appointment and ask your doctor to review it in full, with your current age, your current kidney and liver function, and your current daily experience as the reference point. Ask whether anything on that list was prescribed more than 3 years ago without a formal review since. Ask whether alternatives exist for anything that carries specific and elevated risk in older adults. That conversation, calm, mutual, genuinely informed, is one of the most protective and empowering things you can do for yourself after 60. You are not simply receiving a prescription and walking out the door. You are a participant in your own care, an active, informed, and valuable participant. And the more clearly you understand what is happening in your body and why certain things deserve a second look, the better and safer that participation becomes, for you and for every person who is trying to help you. Now I want to hear from you. Has a doctor ever taken the time to review your complete medication list, everything together, with your current age and health status as the lens, and had that genuinely thorough conversation with you? Share your experience in the comments below. Your words matter here, and someone reading today may find exactly what they need in what you choose to share.